Morena, morena. Kia ora everyone, morena. I hope everyone had a great weekend. Welcome to Dr. Dai's reading on the Mahi Atua page. I'm reading sections from Dr. Diana Kopua. She is a psychiatrist. I am a psychiatrist with a fellow of the Royal Australian New Zealand College of Psychiatrists. I'm an independent psychiatrist, currently working for the Hauraki PHO and alongside another PHO NHC to roll out Mahi Atua services, a space where Indigenous knowledge is prioritised, and we look at racism in all aspects, including internal racism within our practice. And one of the things that we are challenging is the need to move away from a biomedical approach to the design and delivering of services for our people. And I avoided just then saying mental health, and that is because everything needs to be relooked at. And although there are mental health and addiction services, distress, psychological distress is happening everywhere. And mental health services have been designed based on criteria and categorization using the Diagnostic Statistical Manual. And all of those terms, all of those descriptions have come from another place, North America and Northern Europe and America. And so I think that, I have been thinking, and we, Te Kurahana, think that it needs to change. And therefore, we are an organisation that prioritizes the transformation of how we work and prioritising mātauranga Māori. Gee, I'm not multitasking very well at the moment. I'm just trying to set it up so that I can respond to any questions. Let's just check this out. And so I think morena taonui and morena mahinarangi. I'll just get going, eh? Right. So at the moment, I'm on chapter 3, the importance of research. And on Friday, we just talked a bit about the interpreting research of psychiatric drugs. So the next couple of sections, I'll go through the importance of randomized controlled trials and the design of them. Doesn't sound very exciting. Reminding you that randomized controlled trials are considered the gold standard when you're trying to determine whether something is effective or not. However, already we've talked about how there are other ways of gaining evidence that's helpful. Randomized controlled trials are the standard way of testing the effects of drugs on medical and psychological complaints. Like most other psychiatric research methods, randomized controlled trials were originally devised to assess the impact of medical treatments on physical conditions, and were imported into psychiatry with little or no consideration for the issues involved in assessing human behaviours and experiences. Morena. Let me say that again. So this way of understanding was imported into psychiatry with little or no consideration for the issues involved in assessing human behaviours and experiences. Their methodology also ignores the impact of drug-induced effects. Despite these limitations, randomized trials are an important way of establishing that drugs do something that is independent of the natural course of events and is over and above the general effects of having professional care and attention. If we are going to use drugs to help people address the troubling mental states and behaviours we call mental disorders, then we need to evaluate whether they do this effectively or not. That is, whether they actually resolve or lessen the identified problem. Randomized trials can help us to answer this question, although they rarely tell us exactly what a drug is doing and how it is achieving its observed effects. Randomized trials are generally regarded as a robust form of evidence, and their results are highly influential. The UK's National Institute of Health and Care Excellence, which they call NICE, which is responsible for producing national guidelines for NHS medical health and social care interventions, including psychiatric drugs, views randomized controlled trials and meta-analyses, which combine the results of several different trials, as the strongest forms of evidence on which to base its recommendations. The way that psychiatrists prescribe medication is increasingly determined both by guidelines and by individual psychiatrists' understanding of the research evidence. Therefore, it is important to understand the principles that inform the conduct and analysis of randomized controlled trials involving psychiatric drug treatments in order to judge the value of the advice that is issued about these drugs. You can go on Google and have a look at NICE and Google NICE and see how it's this huge pātaka with so much knowledge. And so NICE stands for National Institute for Health and Care Excellence. I remember being a psychiatric trainee, a registrar, so that's a doctor, a medical doctor. I'd done medical school, and after just over a year of being a junior house officer, I went into psychiatry training, and often I was looking at the National Institute for Health and Care Excellence, and often I was given information about research that it was easy to just accept this is the way it was. Now, at medical school, they had taught us how to critique research and the methodology, but very little time in my training did I do that. I wonder how many doctors did actually critique the methodology. And the other thing that I want to say is that Joanna talks about this way of testing treatments and the impact of treatments has come from the physical conditions and imported into psychiatry without little consideration of several other issues involved in assessing human behaviours and experiences. And when we're looking at measuring or determining whether drugs are effective, if those drugs are altering your mind and sedating your mind, and we are doing a randomized control trial to determine whether a particular drug is effective for restricting, let's say, an experience of hearing voices, well, of course sedation is going to alter anyone's mind. So how much of the drug is doing what it would do to even normal people? Well, take two on that. How much of the evidence is determining what the drug does to your normal state of mind versus someone who is distressed with hearing voices? Gee, I don't know if my take two is any better. Okay. Design of randomized controlled drugs. Morning everyone. I'm just checking, just in case you've got any questions or comments that you want me to share. Okay. Before randomized trials became the mainstay of drug evaluation, treatments were assessed by starting the treatment and seeing whether people improved or not. If they improved, it was generally concluded that the treatment had worked. This interpretation might be appropriate if you are certain about how the underlying condition progresses. But many conditions in psychiatry and medicine have a fluctuating and unpredictable course. Symptoms come and go, or they become more or less severe at times. And the pattern of this varies enormously between individuals. Even the most severe mental disorders improve spontaneously from time to time. Therefore, it is necessary to separate the effects of the treatment from the way the conditions might normally develop. It was for this reason that controlled trials were devised. In controlled trials, people are divided into groups. One group is given the treatment that is being researched, and another group, the control group, is not. So we have these two groups, the group that is going to trial the drug that's being tested, and one group that won't trial the drug that's tested. They are listed briefly. Oh, hang on. Wait, lost my page. Both groups are then followed up for a period of time and their outcome is compared. Many of you who have studied will be introduced to this, but I'm going to go through table 3.1 on this book, randomized control trial design. So it starts by defining people who might receive the treatment to be tested. For example, people with depression for a trial of a treatment of depression. That's the population that you're studying. You select a sample for the study. Often younger and older people are excluded, as well as people with other conditions like physical illness. You randomly divide those groups, divide the sample into groups, and then you give groups the different treatments to be studied. And so in a placebo-controlled trial, one group is given the drug and the other group gets a pill. It might be the drug, it might not, they might think it's a drug, but it's actually the placebo. They don't know that it's a placebo. They do know that they're in one of two groups though. They know that it might be a pill, it might not be a pill. It might be the drug, it might not be the drug. Measure and compare the outcomes of the different groups. In randomized controlled trials, participants are allocated to the different groups at random. Randomization is recommended in order to ensure that there is no important differences between the groups that might bias the findings. For example, without randomization, researchers might select people with a better natural chance of recovery to have the experimental treatment and allocate all those with a poor outlook to have the control treatment. Or it could be the other way round. The point is that if the groups are not selected randomly, any differences in outcome cannot simply be attributed to the effects of the treatment. So randomization is applied in order to ensure that before the treatment is started, participants who have the treatment and those who are in the control group do not differ in any important way that might affect the subsequent progress. Kia ora, I'm just reading Taonu's message, and so if you're watching, you can read it as well. So I'm just going to go through it. Yeah, Taonu, these problems are so big and yet so intimately personal, and people have not been happy with the outcome, or actually not just the technical parts. We call it the technical parts of psychiatry. So the assessments we use, the medications we use, but they haven't been good at the engagement, and there's been a lot of need to adhere to a particular process as opposed to be flexible and adaptive and actually sit with the person without predicting what's expected of them. And shock treatment has been, you may have seen an article that I wrote, that I shared with you a little time ago, and so that's pretty much my perspective on ECT. There was a time when shock treatment people weren't given muscle relaxants alongside them. In fact, I think when I started my nursing, that was still happening. Nice. Yeah, and isn't it wonderful that you were able to take her to a tohunga? Now, most people who go into a GP feeling depressed, if that GP is not connected to indigenous healing pathways and communities, then that's not going to be their first option. And I know that as a primary mental health psychiatrist, many of the requests for my support have all many of the GPs have already prescribed the medication. And it is like a spiral effect, right? And many of the public come into the GP hoping for the medication and hoping for a diagnosis. And that's what's happened to all of us as a society. We expect that there is this thing, and if we get it diagnosed in psychiatry, that it can help us get better. But a diagnosis is just a description of what's happening to you, the experiences that you're having, and it might not suit your narrative. I'm deviating a little bit, but let's carry on. So in addition to the safeguard of randomization, most randomized controlled trials attempt to create a situation in which people in the different groups have a similar experience throughout the course of the trial. Ideally, the only difference between the controlled group and the treatment group will be the actual treatment that is being tested. Both groups should experience the same general aspects of care, the same amount of time with professionals and researchers, and the same blood tests and examinations, for example. In drug trials, people in the control trial are usually given a placebo, a fake or dummy tablet, made of an insert substance such as chalk that has no active effects on the body. The placebo is used to mimic what are called the placebo or non-specific treatment effects of taking a drug. Placebo effects are the effects that occur as a result of the positive expectations that many people have about receiving a medical treatment. We know that in some situations the belief that the treatment will help can in itself make people feel better. Some people in severe pain, for example, report that the pain improves after they have been given an injection of saline or water if they believe they are receiving a pain-killing drug. Professionals can also be influenced by their expectations of the benefit of a new drug. The use of a placebo, therefore, is intended to prevent the staff who treat the patient and the researchers who assess the patient from knowing who is getting the real drug and who is not. So everyone's blind. Otherwise, nurses, doctors, and other clinical staff might unintentionally convey their expectations to patients and influence the expectations of patients themselves. Researchers might also be swayed by their expectations when they conduct assessments of people's outcomes. They might be inclined to rate someone they know who is taking the real drug as doing better than someone who is not, for example, even when there is no actual difference between them. When a placebo is used in this way, a trial is described as being double-blinded. This means neither the participants nor the others involved in the research know, and they are not supposed to know, who is getting the real drug and who is on the placebo. So there are many factors that can impact the effect of a drug, and so if a professional who's looking after a patient who's in the randomized control trial is also not aware of whether you have the chalk pill, the placebo pill, or the actual drug being tested, then they are working to eliminate or restrict as much as possible that bias. Gee, I want to keep talking about something else, but I won't. It is because double-blinded randomized controlled trials are carefully designed to minimize the influence of factors like selection and the effects of expectation that they are often referred to as the gold standard of treatment research. The results of different trials of a particular treatment are often combined into a single result using a statistical technique known as meta-analysis. Studies using this technique are highly influential and often form the basis of guideline recommendations made by expert committees, such as those produced by NICE. A meta-analysis is only as good as trials on which it is based, however, a fact that is often overlooked. By combining studies, meta-analysis is a powerful instrument that can yield results that look strongly positive. But a meta-analysis of poorly conducted trials not only adds together their outcome scores, it also summates their deficiencies and biases. This means the results of meta-analysis may be more misleading than the original studies. So a meta-analysis is the sweeping together of all studies that are very, very similar, and strengthens the idea that the outcome of the studies is, either positive or negative. But if those deficiencies or biases are swept in as well, then actually it can be more misleading than the original studies. So randomized controlled trials compare the outcomes associated with different interventions or treatments. In psychiatric drug trials, these outcomes usually consist of scores on symptom rating scales, such as depression scales. Stay with me. Statistical tests are applied to see if there is a genuine difference between the average scores of the two groups, or alternatively, if any difference that is found is merely due to chance. It is the difference between the groups, if the difference between the groups is big enough, the study has enough participants, then the probability that the difference occurred by chance will be low. The probability is known, as the p-value. And when this is less than 5% or 0.05, then the result is considered by convention to be statistically significant. This means that there is likely to be a real difference. So the test is the study is trying to find out whether the findings that we got from the randomized controlled trial are a real difference or just by chance. In fact, there is a 95% or greater chance that the difference is a real difference if the p-value, is less than 5%. Welcome to statistics. However, 5% or less of the time, the results will show a difference that has occurred just by chance, when there is no real underlying difference. Many studies use numerous different outcome measures that can be analysed in different ways. Researchers can look at the scores of a scale at the end of the study, the amount of change over the course of the study, and how many people reach a certain threshold score. Or they can look at the scores in other ways, and they can do this for each of the measures that they have collected. This means that multiple tests are conducted. If researchers do 100 tests, then even if there is no real difference between the groups, on average, 5 of these results will be statistically significant using the conventional 5% cutoff value just by chance. Woo! Now, tomorrow I'm going to talk about the problems with randomized controlled trials of psychiatric drugs. But what I was going to say earlier before, and there is another, hang on, I'm being joined by someone a little bit prematurely. Hang on a sec. I'll talk about it tomorrow. Okay. No, she's gone. Okay, so what I really do want to talk about is the randomized control trial, and I'm not sure if they'll talk about it tomorrow when we do the reading, but what's been excluded is you, the professional. Those factors are huge and often missed in studies. The biggest variable when we're looking at outcomes is the therapist. We're not often looking at that. So consider that, and I'll see you tomorrow. Ngā mihi.